So if you were picking up the phone to talk to a community neurologist who had a patient in their office and they said to you, I'm concerned that this patient may have this diagnosis, what would be the questions that you would ask of a community neurologist to say, have you done this, have you done this, have you done this, to get the preliminary workup to know that they're on the right road to making that diagnosis before they even get to you?
I think that first and foremost is listening to the patient. What Sebastian said to us was that it had become something that had been impacting his life. It was setting him apart from his peers. It was not only setting him apart, but it was getting worse over time. He was having more trouble. Once again, there is that feature of regression or loss of previously gained skills. At that point, when you have someone who is telling you that they have weakness and you're visualizing a degree of weakness in front of you, one of the first tests to do is a muscle enzyme test looking at CPK. If it is elevated into the multiple thousands, 15,000, 20,000, that indicates constant muscle breakdown from a process like muscular dystrophy. So
that was my next question.
Yes.
So we're going to be talking shortly about some of the specific treatments for spinal muscular atrophy. Now, for somebody who's not specializing in this area, we know that there are other neurological issues like muscular dystrophy, and yet these treatments that we're going to be talking about are very specific to spinal muscular atrophy, and yet with other issues like Duchenne muscular dystrophy, I'm sure there's a very similar presentation of these kind of symptoms that patients present with, yes?
There are. And so it's important to make sure that we're kind of going down the right path. Are we dealing with muscle, which is dystrophy, or nerve and neurogenic abnormalities, which is SMA? So the CPK can be mildly elevated in our patients that have SMA, but not to the degree that it would be for a dystrophy. So one test to at least add to the list. And then these days, it's actually incredibly easy to test for spinal muscular atrophy with no cost to the patient because of funding and support through various organizations whereby that SMA testing can be done at no cost and return within a week.
And we've heard also about how Sebastian initially was getting physical therapy for tightness in his lower limbs. Is that a common presentation that patients are going off down these other avenues and coming to you through, not just through physicians, but through patients who have been taken care of by other support systems like physical therapy?
Absolutely. I really enjoy talking with my physical therapy and occupational therapy colleagues because they may actually see these patients before they see me. Many times it's, I think, pretty typical for many doctors that if you have weakness or if you have discomfort or tightness, I'm going to send you to PT to see if I can make that better. And I think we need a little bit of a mind shift here where we can continue to try to make it better, but we also need to figure out the why. And I am where the why hopefully comes from.
Right.
And so doing both at the same time is really what I would urge, these neurologists and primary care people to do.
One of the things that I remember very clearly from medical student days doing pediatrics, that you guys love to draw a family tree and plot out brothers, sisters, mum, dad, cousins.
Yes.
Do you take value in asking questions about family tree to identify who may be the carrier, whether other children in the family may be affected? How important is it to look at siblings like Sebastian to know whether there's other people in the family that may have an undiagnosed spinal muscular atrophy as well?
It is autosomal recessive, and so it's a little bit more difficult than if it were autosomal dominant. So there are many, many families who have no other family member diagnosed with spinal muscular atrophy. And so a family tree, while in pediatrics, you're right, we do consider that very important, may not actually be telling. And so in the event that there's no one else in the family with a muscle or a nerve condition, it does not mean that this is not SMA.
And you talked about the inheritance, the autosomal recessive versus autosomal dominant. Can you drill down on what that means for the layperson when you're explaining to mum and dad about the inheritance of this disorder, particularly for parents who are thinking about other children? Can you explain what that means, autosomal recessive?
So for Sebastian, it means that most likely His mom was a carrier, and as a carrier, you are not typically symptomatic, so mom would have no way of knowing that, that she was a carrier. She would have no muscle weakness and otherwise would be a healthy individual. Dad was also likely a carrier, and once again, asymptomatic, no way of identifying that he was a carrier. And those two individuals have a child who then has a 25% likelihood of having spinal muscular atrophy.
Dr. Proud, it always makes me smile when patients have a diagnosis and without understanding treatment categories or disease categories, they always seem to want to know, am I stage 1, am I stage 2, am I type 3, type 1? And yet often there's not a clear understanding of what these different disease categories actually mean. As far as SMA is concerned, we've heard about type 1, type 2, type 3. How do you break it down and categorize the disease?
So these days, I actually do not categorize any longer. And the reason for that is because we're in an era of treatment, whereas someone who used to be a type 1 is now defying that category. But I can refer to it in a historical sense. So we refer to someone as being a type 1 patient if they never reach the ability to sit. So that's going to be our infants with spinal muscular atrophy. Usually they present with profound weakness in the first 6 months of life. A type 2 patient reaches the ability to sit but never stands and walks. And then our type 3 patients reach the ability to walk, though many of them actually without treatment would lose that ability. And so Sebastian would be characterized, if I was characterizing him, as a type 3 patient who has the ability to walk.
And you mentioned type 3 as the ability to walk, but it's not black and white, walk or not walk. Do you find that patients in that type 3 category, some are walking but it's delayed walking, or they're walking at the time they're expected to, but their posture may be different, the balance may be different?
Absolutely. So Sebastian walked, in talking with his parents, at the time that one should, so he walked before the age of 1, but his parents noticed at about the age of 3, or by the age of 3, that there was a difference in the quality of your walk. And that is pretty characteristic of many of my patients, is that even if no one else recognizes it visually, they feel different. They're not the most athletic kid. They'll have more tripping and falling, things like that. And some of my patients who are categorized or would have been categorized as a type 3 patient, they actually lose the ability to walk and may need a wheelchair, even a power wheelchair, to be able to maneuver in the environment. And as we think about these types, it's critical to recognize that it's a phenotype, that the DNA is the same across all of these phenotypes. All of these patients have a missing or mutated SMN1 gene. They may have a different number of copies of that backup gene, which may help facilitate what that phenotype looks like.